to today. Today's talk is Pre-Hospital Head Injury Management by Jack Barrett. So these webinars are brought to you free. They are sponsored by Slater and Gordon and also by people having memberships to Trauma Care. Trauma Care is a charity, and our remit is education, and the webinars form the core of that. And as you'll see shortly, it's the members and the membership that is the key to our organisation. Next slide, please. There is a disclaimer we give at the beginning. There is a wide range of job title, ability, function, and this learning taking place during this webinar should not be solely relied upon to inform practice or indeed allow practice outside the individual's scope of qualifications. You should very much follow the protocols and policies of the organisation that you work for. So if you're not a trauma care member, why aren't you a trauma care member? You should be a trauma care member. The prices are there. The certificate itself costs £3, and we do one a month. So you can already see that by becoming a member, if you're not a registered professional and you're not a student, or if you're a student, it's the same price, and you get the benefits of trauma care membership. Full members, it's only £8 per month. You get access to all the webinars. You get the certificates automatically. You will, without paying, sorry. You also get access to the trauma journal every quarter, and you get access to discounts on conferences organised by Trauma Care. Thank you. I'm going to introduce Jack Barrett. He is a Paramedic Senior Research Fellow at South East Coast Ambulance Service NHS Foundation Trust and the Air Ambulance Charity Kent, Surrey and Sussex, where his research focuses on pre-hospital emergency care, particularly the management of TBI in older adults. He's been a paramedic since 2014. He transitioned into research in 2017 and has since developed a growing portfolio in traumatic brain injury and pre-hospital care, supported by the College of Paramedics and the NIHR. Jack completed an NIHR Clinical Doctoral Research Fellowship in 2023, earning a PhD in Health Sciences from the University of Surrey, where his work centred on improving clinical decision-making for older adults with head injuries. He has co-authored multiple peer-reviewed papers in relevant pre-hospital and emergency care journals and has presented his work at national and international conferences. He has also led national collaborative projects. Across his clinical and academic work, Jack is committed to advancing evidence-based practice and improving outcomes for patients requiring urgent and emergency care. So welcome, Jack.
Hi, good evening, everyone. Let me just get my slide on and share that with you. Thank you very much to Trauma Care for having me this evening. And I think this is close to sort of one of the largest groups I've spoken to about this work. So it's a pleasure to see you all. So we're just going to dive right into it. There's quite a lot of content to get into this evening. A couple of declarations of conflicts of interest. I'm going to be sharing some of the research I've done from my PhD, which was funded by the National Institute of Health and Care Research. So any views or things I share about that work, they're sort of my views and not necessarily that of the funder. I was also involved with for those of you in the UK that might recall the position statement that came out following the NICE head injury update a couple of years ago, position statement from ARCEM and AACE and a few other organisations. I was involved in sort of the writing that and the update of the most recent JRCALC, so that's the UK ambulance guidelines for our international colleagues, the update in the guidelines there. I'm going to be talking about some of the stuff that went into that update later on in the talk, but again, sort of talking it from my point of view, and again, not necessarily representing the views of these organisations. So, what are we going to be talking tonight about? So, we're going to talk about people like this, essentially. So, yeah, as you heard, I've sort of been a paramedic now for, I don't want to look at my watch because I don't recall the years on that, but a good sort of 12 plus years now. And one thing that I always stuck with me, especially in my training and early years, and still recently when I do occasionally get out on a truck, is these sort of patients, these older adults who perhaps fall of their home. And I always remember sort of the biggest concern after a hip fracture was whether or not they've hit their head and whether or not they've got an intracranial bleed. And one of the things that was most pertinent to me was these patients that were perhaps on an anticoagulant, and back when I first started, warfarin was the most prevalent anticoagulant. And I always remember sort of colleagues saying to patients, "While you're on this medication, you've got to go to hospital." And being sort of quite new to the profession and not long out of training, I'd always sort of ask, "Well, why?" And there doesn't seem to be anything else wrong with them, but there's a risk of a bleed. We don't want to miss a bleed, and that patient should we need to get that patient into the hospital. So, and this really sort of started to sort of snowball and led me down to sort of why we need to sort of explore this area, and we'll sort of hopefully go through that journey through tonight, through this evening. What I just want to sort of again just preface this talk with is when we talk about sort of traumatic brain injury, we're actually talking about a sort of a real sort of spectrum of injuries that TBI cover, and that's sort of those ones I think in our pre-hospital setting we're perhaps most concerned about that intracranial hemorrhage. So whether or not that's an epidural or subdural hematoma, so those bleeds around the dura, or those bleeds in the brain, so your subarachnoid and intracerebral hemorrhages. And interestingly, sort of the epidural and subdural hematomas, they are not necessarily a brain injury to begin with. Yes, there's blood sort of expanding following a ruptured vessel in or around the dura, but until that blood expands so much that it starts pressing on the brain, those initial minutes or hours, depending on the patient, there may not be a brain injury to start with. And then there's, of course, sort of concussion and diffuse axonal injury, and they all have different pathologies and mechanisms behind them. And again, as an example, sort of your epidural hematomas, they're typically mechanisms where something has come and hit your head, whereas a subdural hematoma, they're more likely to occur when your head has hit something. So again, we'll just bear that in mind. I'm going to use TBI quite generically tonight, but just have that working in your back of your mind that there is an array of different pathologies, and hopefully in the future we might actually get the opportunity to really sort of identify them early on and target them more appropriately. But anyway, tonight I'm going to try and cover 4 areas, sort of quite ambitious for sort of 45 minutes, but we'll work through this. So 4 things I want to cover. So top left, we're going to talk about this chap and older age and frailty, and sort of 10 points in the chat if you recognize who this person is and why it might be pertinent to older adults. We're going to talk about the clinical guidelines and how my sort of research has been influenced by them and hopefully influence them. Those unwitnessed falls in care homes or residential nursing homes, something for those of you definitely at sort of 2 o'clock in the morning, patient found on the floor, no idea what happened to them. And actually there is some evidence there to tell us what sort of injury profiles they're likely to have. And then of course those anticoagulants, how much of a risk are they in older adults? So this graph is a couple of years old now, and for our international colleagues, this is UK specific, but this is a global problem in definitely in a lot of developed countries. So we are in an aging population, and currently we are looking at in the UK, I believe the ratio is something like for every 1 person that is retired, there are 3 people working in the economy. Now, when the pension age was sort of first came about, sort of 115, 20 years ago now, there were 20 people working for every 1 person that's retired. And we're sort of expecting to see by 2050 that ratio is going to go to 1 to 1. And once we get to that point, I mean, we already have globally quite a few economic issues, but once we get to that point, we're going to really sort of struggle both in terms of economy and our healthcare. And it's probably on a par with sort of the climate crisis that we're also experiencing. And colleagues in countries like Japan, Singapore, a few other places where we're seeing the economic effects with an aging population. And this, I guess, is we are sort of victims of success in some respect. So when we think about an aging population, actually, where we are predominantly, and again, I'm talking perhaps some of the sort of in a Western context, in developed sort of economies, we are aging quite healthily. And for the healthcare professionals on the call, that may not necessarily be resonant with us because of the patients we see, and actually they may look something a bit more like this. So this patient could be 65, they could be 105, and there are some quite telling things from this picture that I find. So again, the armchair looks quite seasoned, I would call it. So this lady here clearly spends quite a lot of time there. She's got her magazines to the left of her. She's got a box of tissues, a cup of tea, all within arm's reach. And then we look at sort of the clothing she's wearing as well. It's quite loose fitting and it's quite bright. And it's not because she's lost a lot of weight. It's because she needs some help and support in changing. And it's easier to change someone when that clothing is loose. And if she spills something down her, it's easier to sort of spot that spill as well. So she's not left there sitting in soiled clothes for hours on end. And while we're trying to sort of, the reason we're sort of, the system is doing this, as it were, is because this old lady is at a risk of fall, and we get into a bit of either self-fulfilling prophecy or a bit of a spiral here because when she gets up to walk, she's unsteady. If she doesn't have any walking aid, she sort of has to sofa search or furniture surf to get from one place to the other, and we don't want her to fall over, so we actually sort of keep her in one place, and as a result, she becomes weaker, and it becomes more difficult for her to sort of get up and walk and move forward. But the point of this slide here is that age is really just a number at this point, and it doesn't really tell us anything. And this is why sort of frailty now is becoming a bit more, I say a bit more, very important in really sort of helping us to understand sort of older adults. Because at 74, you could be a power lifter or bikini model, or you could be sort of quite immobile. So when we think about older adults and age, well, there's probably quite a bit of bias there. We need to sort of shift that. And older age and an older adult, sorry, generically in the trauma literature at least, has been defined as being 65 and older. And when I first started my PhD, I wanted to understand, well, why 65? Because some of the work I'd been doing in sort of older adults and TBI, actually the prevalence of TBI in an older adult actually sort of started to peak around 50 and sort of and start from there rather than the 60. And the reason sort of 65 from what I glean is because of this chap. So for those of you that aren't aware, so this is Otto von Bismarck. He was the Chancellor of Germany in the late 1800s, and this was the first place to actually to come up with a pension scheme because they realised that we needed to look after our older adults. And originally the number was going to be 70, but there was quite a bit of public unrest about that because actually at that time life expectancy was such that you weren't really going to be around long enough to enjoy your pension. So they brought it down to 65, and it's sort of stuck there ever since. In some disciplines, especially psychology, they're sort of defining types of older age by age a bit better. But in trauma care, we've sort of picked up on this, and it's sort of stuck ever since. And really, I personally think that's sort of a bit outdated now. We need to really sort of think about how, if you're going to define an older adult, what that actually looks like. And so much so, 65 is actually quite young now to retire. Sorry for those of you that are sort of approaching retirement age. But we are seeing now people sort of living longer through retirement than they are actually sort of working. But this is why sort of frailty is quite useful for us. And I appreciate we've previously had a chat not too long ago by one of our geriatricians talking about frailty. So I'm not going to linger on this too much, but it is starting to come and seep through into the TBI literature. And to begin with, it's really just looking at sort of prognostication. So if you have a TBI, what's the interaction with frailty? How do we sort of, what are the sort of expectations with those patients? But there is something I just really want to sort of highlight with regards to sort of frailty. Age in the UK is a protected characteristic. You can't discriminate against someone because of their age. You can't say, no, you can't have this treatment or this intervention because you're 65 or 75 or 85 or whatever else. But you can say that with frailty. And this is something that we definitely saw in the pandemic, where patients who were particularly frail were being sort of denied is probably the wrong word to use, but weren't getting access to intensive care or high dependency units because of their frailty, not because of their age. And there is now sort of a term called frailism, where we are consciously or unconsciously discriminating based on a patient's frailty status. But interestingly, it is, as I said, coming into the TBI literature. This was a really interesting work from our Dubux and colleagues, and they were looking at where you hit your head when you fall over, and your frailty status, and the likelihood of having some sort of intracranial bleed. And they did sort of find some signals to say that the frailer you are, the more likely you were to have a bleed, especially if you hit the front of your head. But this work hasn't, to the best of my knowledge, hasn't yet been validated. This paper came out a couple of years ago now, and it was with a relatively small cohort of patients. But it's just something to sort of consider when you're assessing those patients. Sort of where have you hit your head? And that's not something we necessarily always record, but there is work in progress here in this area, and something we need to be mindful of. So, a little bit just to sort of consider when we sort of think about TBI in the older adult, we need to start perhaps just shifting towards frailty and what that looks like. And definitely in your local systems and EMS services, please record that frailty status of your patient. And that'd be really helpful when we start to look at these, do national bits of work and sort of map TBI and head injuries. Having that frailty information make a real difference for us in understanding this population. So a little bit about sort of again, go back to the research that I've done in this area, and it was sort of spurred on very much by sort of the guidelines that we have for older adults. Now, the guidelines we have with regards to sort of conveying older adults following a head injury, a lot of them I don't really have any issue or dispute with. I mean, if you're symptomatic with those classic head injury signs, you should be going to the emergency department, because you are at risk of some sort of underlying significant head injury that requires further workup. But one sort of guideline that I do sort of think needs a bit of a rethink for us is if the patient is on a sort of current anticoagulant therapy such as warfarin, and they've got no other sort of red flags, we still recommend that they go into the emergency department. So I looked in this, not specifically at this in my PhD. This was sort of a byproduct of it. But one thing I've always been quite conscious of is in the literature that came out about 10 years ago now, was this thing that GCS, so Glasgow Coma Scale score, doesn't always map with the severity of injury. And that's to say that in older adults, we were seeing quite a lot of older adults in the trauma system presenting with a GCS of 15, 14 if they've got some dementia or Alzheimer's, and presenting with quite significant head injuries. And there became this point that even if a patient didn't have these classic head injury symptoms, they could still be at risk of a TBI. And so I wanted to look into this in a little bit more detail in my PhD, and understand what things should we be looking out for in these older adults, because it wasn't necessarily clear, and GCS wasn't particularly helpful. So this was work done a few years ago now, back during my PhD. This was 12 years, 12 months worth of patients in Kent and Sussex. So that's in the southeast of England for our international listeners tonight. And I collected data on just over 3,500 patients that presented to our ambulance service. And of those, 2,000 patients went to the emergency department, and I followed those up and looked at their their emergency department records. And what was quite interesting here is that a fair proportion did have a head CT scan following their head injury. And I will say anyone that sort of refused a head CT scan or refused to go to hospital were excluded from this. So these were what we call willing patients to follow through the system. Now, of those 1,600 patients, only about 10% were found to have some sort of TBI on their head CT scan. And TBI in this context, I was looking for those intracranial bleeds. Most got referred to neurosurgery, but only eight actually got accepted. So when you think back, those 3,500 patients, there were only eight that actually ended up getting accepted for some sort of neurosurgical under the care of neurosurgery. So whether that was under just going onto the ward or having some sort of neurosurgical intervention. So it really is looking for a needle in a haystack in the pre-hospital setting. So let's just sort of delve into this in a little bit more detail then. So what did sort of the volume of patients look like? So 2020, that classic year for us in recent history. So this was during the pandemic, the COVID pandemic. And what we're seeing here, sort of January to December, is in England, our first lockdown was in April. So we were seeing sort of a steady decline in overall volume of head injury patients presented to the ambulance service. And then after that first lockdown, sort of a big shift as the population wanted to become more mobile again. But what was more compelling for me was actually looking at the patients that we conveyed and non-conveyed during this time. And what we see here is that conveyance rate, that teal bar there, that was dropping up until April. And this was the only time I think I've been able to see this so far. It's actually for our older adults and our head injured patients. The non-conveyance rate, so discharging at scene or referring elsewhere, was higher than the actual conveyance rate. There was a default normally to sort of take these patients to hospital. And that was really interesting to see because I think for the first time, the risk of going to hospital was actually greater than staying at home, or the perceived risk from our healthcare professionals. So I sort of explored this and sort of looked at some of the things that influence whether or not a patient went to hospital or not during the whole year. And adjusting for other factors, and odds ratios here. So adjusting for sort of other factors, not being conveyed to the hospital, being discharged. The thing that was most associated with that from a comorbidity point of view was actually if the patient had dementia or Alzheimer's, and this was likely to be due to the fact that taking these patients, these are vulnerable patients, and taking them to the emergency department, which is very busy, very noisy, it's not their normal setting, can be quite disorientating and upsetting for them. And actually, the risk of going to the emergency department is probably greater than the benefit. But also what we found is reasons for going to the emergency department from a comorbidity point of view is if patients had a previous MI or diabetes, there was either sort of 2 times or 2.5 times more likely to go to the emergency department. And we didn't really have the context or detail to understand why. And it could be the fact that most of these patients, I should say, about 3/4 of them had some sort of, or 80% had a fall from standing height. There are a few other sort of high risk mechanisms, but most of these patients were falling from standing height. So it could be that actually there was some underlying pre-existing condition that was causing these patients to fall, and that might be the reason why they're going to the emergency department rather than the head injury itself. But if we look at some of the clinical presentations as well that we found, if you could see a bruise or an injury on their head as opposed to not, that was more likely to cause you to go take that patient to the emergency department. Of course, if you had a GCS lower than 15 or some other sort of sign or symptom of a head injury, that was also almost guaranteed to take you to the emergency department. And in South East Coast Ambulance Service, we have a spectrum of clinicians from emergency care support workers, your sort of traditional ambulance technicians, to paramedics, and then specialist paramedics with extended training in both urgent care and critical care. And what we found is compared to our non-paramedic colleagues, if a paramedic attended an older adult with a head injury, there was about a 30% chance they were less likely to go to the emergency department. And if our specialist paramedics, especially in urgent care, were to attend these patients, there was pretty much sort of a 98%, 92% chance that that patient was not going to go to the emergency department. Now, I will caveat that and say that our specialist paramedics and CCAM at the time, they could self-deploy to incidents. So there's probably a bit of self-selection here, or a selection bias going on. But what this does tell me is for our older adults or our vulnerable adult groups, we perhaps need to sort of think about sort of the resources we are sending to these patients, and having that sort of specialist input, to really sort of help support and understand their needs. And perhaps that's because of their extended knowledge or scope of practice, or they have access to other pathways that perhaps other colleagues may not. I will say that unsurprisingly, if you were taking aspirin, clopidogrel, warfarin, or the direct oral anticoagulants, that was pretty much guaranteed you were going to hospital when we looked at it in our at our on-scene population. So, what about actually when we get the patient to hospital? What were the sort of factors that were associated with finding an intracranial bleed, in those patients? And remember, we're talking about sort of 160 here out of 3,500. So, what was really interesting out of this piece of work, and this is published in the Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine, is actually it wasn't necessarily the classic things we associate with a head injury, that was associated with a bleed. So patients with a history of ischemic heart disease, um, chronic kidney disease, some sort of clinical symptom associated with a head injury or a dangerous mechanism. These were the things most associated with these patients having a bleed. So starting from the top, we're sort of 3 times more likely if you've got that history of ischemic heart disease, or some sort of heart comorbidity. Chronic kidney disease, about 2 times, 50% chance if you had some sort of clinical symptom, and then sort of 3.5 times or 3 times more likely if they were to sort of fall from a ladder. So really interesting stuff. And I will say I did check, because when you think the heart, you're probably thinking, well, they're probably on a DOAC anyway or an antiplatelet. That didn't factor into it. And with our chronic kidney disease, we've seen some literature in hemorrhagic stroke, that actually there are perhaps some proteins that are released that make the vascular more permeable because of chronic kidney disease, that make those patients more susceptible to hemorrhagic strokes. So there might be some sort of interplay there, and that's been demonstrated with some of our colleagues from North America, that have also sort of found that when they've been looking at this patient group. So quite an interesting find, and not something I'd considered in my clinical practice previously.
Jack,
As Oh yeah,
Jack,
go
can
on.
I just ask a quick question? Can you go back one slide, please? Could you
Yeah,
explain
sure.
what AOR? That's one of the questions that's come through.
Sorry, what was I
Right, could
missed?
you explain AOR, please?
Oh, sorry, AOR. So yeah, so this is adjusted odds ratio. So this is the the chance that a patient with this condition is likely to have a bleed, and the A is that we've adjusted it for age, sex, and some other co-founders as well. So, so all things being equal, if a patient has, say, a history of sort of heart disease or chronic kidney disease, they were 3 times or 2 times more likely to have an intracranial bleed on their scan. Now, I will say that the study wasn't powered to find this out specifically. So this is not necessarily a causation. It's just uh, uh, I've lost the word now. Um, uh, completely lost the word, but it's not a
Causation?
causation. Yeah, exactly. Thank you. Um, so um, so yeah, so just be mindful of that.
Can I
But
ask
it's
you
the
another
sort of thing
question
that we're
as
starting to
well?
see. No, go on.
Yeah, so we've also been asked why were only 8 accepted in this study, as in what was the reason? Was it because the rest didn't require it or they weren't fit for surgery?
The line that typically comes out, or the notes, if it was reported, was either for conservative management or not for neurosurgical intervention. Now, The reason for that maybe is actually the size of the bleed was quite small in these patients. So it may be that they didn't actually need a neurosurgical intervention in the first place. So what we need to remember as well is as we get older, our brain does shrink. And with a small subdural bleed, it could be that actually that just needs conservative care, and that blood will eventually drain away. What we need to be mindful of that particular group is if that bleed keeps expanding and it becomes sort of subacute and then a chronic subdural hematoma, and that can sort of sit on the brain for some time, days, a week, months, and then start to cause neurological problems, at which point that patient might be considered for evacuation of that hematoma if appropriate. And chronic subdural hematomas were excluded from this group. So these were patients with first presentations, not patients who had perhaps hit their head a few days or a week before their presentation and developed symptoms. I was looking for those acute presentations. So now, as I said, if you're on an anticoagulant or antiplatelet medication, that was a guarantee. That was a guarantee to go to the emergency department. When we actually looked at the chance of intracranial bleed and the different types of these medications, what we found is actually aspirin, warfarin, and direct oral anticoagulants, they weren't associated with an intracranial bleed. Now, clopidogrel was. And I think there's a couple of things here just to consider. So again, I will caveat and say that this study wasn't powered to look specifically at the risk of intracranial bleeding in these medications. But I think what we need to remember here is a couple of things. Is aspirin, when it was first developed, it was developed as an analgesia, and it was found through some of the pathways that it acts on actually also had antiplatelet properties, but not necessarily a strong antiplatelet. Whereas clopidogrel, that was developed specifically to be an antiplatelet. And what that antiplatelet medication, that clopidogrel is doing, is when you have a rupture in your vessel, it's delaying that platelet or that plaque forming over that rupture, because this was for our cardiac patients who are at risk of atherosclerosis, and we're trying to stop plaques from sort of building up in the coronary arteries. But of course, there are side effects, but there are other risks we need to consider by taking this medication. So that's something to sort of consider with our clopidogrel patients. The anticoagulants, that's only a problem really if we can't plug that hole, because then we're going to keep bleeding into it. But that's still going to be the same problem, same issue with patients not on anticoagulants, if that makes sense. So that's what sort of the study found, and has sort of helped us inform how we might, amongst other things, how we sort of developed the recent sort of guideline updates. But let's just have a quick look at the history of the guidelines, as it were. So one thing I always remember from being on the road is this phrase: if you're over 65, you're at a greater risk of a significant head injury. And it wasn't until I started looking into the guidelines or the history of the guidelines as to why that might be the case. And so I think for all of us around the world, we're probably most familiar with the Canadian head CT rule for patients. So this really sort of kicked off CT head guidelines. Before this, it was a bit of a wild west in the emergency department. So before 2000, if you came in with some sort of head injury, you may or may not have got a scan, but there was no, excuse me, there was no agreed set of rules of which to sort of scan these patients. And there are other rules out there, but the head CT scan ruled it. So what was it about this work that meant that if you're over 65, you're at greater risk of a bleed? So it all comes down to how patients were included in this study. And I'll just highlight this. You can go away and sort of read this afterwards. But essentially, patients were excluded if they were, okay, so if they were under 16, so kids were excluded, and there are separate guidelines for children with head injuries, had minimal head injury. And so what they said here is basically if they didn't have any sort of clinical signs or symptoms of a head injury, they weren't included. And patients who were on anticoagulants at the time, so and it was predominantly warfarin at this year, so 25 years ago, they were excluded as well. And this is quite important because when we actually look at the patients that were included in the development of the head injury guidelines, they were quite young. So the mean age, so the average age was just under 40 with a spread of about 18 either side. So that's sort of 60 to sort of 20. Now, while the range was all adults, it was quite a young working age group and predominantly men. So 70% of men were involved in this. And what we know about older adults and falls and head injuries, it's actually populated very much by women. So there's a couple of things here just to bear in mind. But when they started looking at the rate of intracranial bleeds or those brain injuries, what they found is actually the patient age was somewhat older than the average, so close to 50 now. And a third of the population that had a brain injury were over 65. So what that then meant is that 65 became a risk factor. So if you were 65 and older, you had about a 1.5 times chance to have some sort of significant finding on your head CT scan. And so this is where that 65 and older came from. But it's 65 with symptoms of a head injury, not 65. So this is your ambulance driver's whispers coming in here now. It's not, and why it's really important to sort of understand how our guidelines and our understanding of these pathologies work and where that evidence comes from. So being over 65 for the last 25 years, if you hit your head, there's a bit of a bias here that we just need to sort of be conscious of. Now, more recently, some colleagues in Canada, so Kirsten DeWitt and colleagues. Kirsten does some really interesting work in this area in Canada. They've actually looked at the incidence of intracranial bleeding in older adults who present following a fall. So no other mechanisms, just fall. And what this systematic review found is actually the incidence of bleeding was about just over 5%, so 5.2%. With a 95 confidence interval of 3 to 8. And so what that means is while that 5% is we're 95% confident that it's about 5%, but it can go anywhere as low as 3 and up to 8. And this review included sort of all comers. They didn't exclude patients who might be on anticoagulants or any other risk factors, but they did what's known as a sensitivity analysis. So where papers might be unduly biased, they pulled those papers out and just looked at the high quality stuff. And even then, the risk of bleeding was about 5%. So about 5% in sort of the older adult falling population. Now, when we go and look at systematic reviews that have looked at anticoagulants, antiplatelets, and whether that's again DOACs or your warfarin, there is a real mix of studies out there with different sort of methodological rigor. But what I will highlight is this paper in the bottom right here by Gordon Fuller and colleagues from Sheffield, where they've looked at direct anticoagulants, direct oral anticoagulants, sorry, and the risk of bleeding in this group. And actually, your GCS 15 patients with no other sort of signs and symptoms, actually their risk of bleeding is probably no different from the wider population of older adults and fallers. So again, sort of in that 5% space. But again, we don't have any sort of decent primary research to sort of pin our hat on and actually say this is what the risk is. In those asymptomatic head injured patients, we don't know what the risk is, but it is somewhere in that sort of 8%, 5 to 8%. So not that much higher. And part of my postdoc work now is trying to get funding to actually look at these older adults following a head injury, but don't have any of those classic symptoms, but do take these medications. What is actually the risk of bleeding in that group? And yeah, just to say, while it's the signal from the literature is there, it's really difficult to sort of confidently sort of move forward with this. But this work has helped us informed our clinical guidelines in the UK in the ambulance service. Now, just a couple of updates here for our UK colleagues. That you may have hopefully seen in the last 12 months when this went live. It was really difficult to sort of steer away from NICE. So that's our national guidelines. And we couldn't sort of deviate too much from there, but we were able to sort of expand on the older adult and head injury section. And there are a couple of things I just wanted to sort of to make clear for clinicians. So our clinical guidelines for patients on anticoagulants in NICE. Historically, there was a these patients should have a head CT scan, and that wording changed a couple of years ago to consider, which actually gave clinicians a lot more flexibility as to whether or not older adults should have a scan, because there are some instances, especially for vulnerable older adults who perhaps have some sort of cognitive decline, where actually putting them in a head CT scan could be um, quite distressing for them, and they might need sedation, and that comes with its own risks as well. So the risk profile just to find out whether or not a patient has a bleed gets greater and greater, with not much return for that patient. So what we wanted to highlight here is actually these patients might be considered for a CT scan. Rather than they will have a CT scan, and then this long blurb here, which I won't read verbatim, but this took quite a bit of time just to get the reading right, the text right here. But essentially, what we're saying here is that because it's a consider, crews on scene should not now just think that because these patients are anticoagulated, they're definitely going to get a head CT scan, and they should definitely be going to the emergency department. Because what we found through some qualitative work by interviewing paramedics, non-paramedic ambulance crews, and some ED colleagues, is actually when you're presented with that patient that patient who is anticoagulated, in some cases you sort of stop there. You think, well, you've got to go in, you're going to go to hospital because that's what the guidelines say. And I noticed this both when reviewing case reports, patient records, should I say, in the ambulance service, and speaking to colleagues through interviews, is you kind of think, well, they're going in anyway, and you sort of take your foot off the pedal. And what I guess we're concerned about is actually there might be another reason why that patient fall. There might be something else going on there, but because you're focused now on just the anticoagulant issue and that patient might have a bleed, that other issue might not be flagged up to the triage team when you take that patient into the emergency department. And it might not even be picked up because again, you've said they're coming in for a head CT scan, and you might be sending that patient down that trajectory. Now, I'd like to think that that would get picked up eventually, but as we know, our emergency departments are very busy, and it's very difficult to sort of give the time and resource needed to be as thorough as you can. And we're in quite a unique position in the ambulance service because we typically just have one patient in front of us. I know sort of control can call us up sometimes and tell us to get a move on, but we're very much in control of our environment. We can really spend that time to sort of understand the patient. So those guidelines were sort of updated to essentially give clinicians a bit more flexibility and scope, and invite senior clinicians to have those calls on scene to sort of discuss what's best for the patient. And importantly, have that patient involved in the conversation as well. Really understand what their concerns are more than anything else. And that's the thing. The guidelines here are your parachute to sort of navigate this. But we've really got to understand what the evidence base is as well, supporting those guidelines. Much like sort of a parachute, you do need it if you want to go skydiving twice, but it's not enough just to be handed the parachute. You've got to understand how it works as well. So that's just sort of a sort of whistle stop tour of sort of the research and some of the work we've been doing in the pre-hospital space, looking at the risk of bleeding in this group, and it's perhaps not as big as we think it is. But I'll pause there just to sort of take any questions. I know this is a pretty hot topic, so I'll do what I can to sort of fill some questions. Then we'll go on to some of the other fun stuff as well that's going on.
We've got a lot of questions, so we'll take some of them now. Um, Stephen Hobart, I did type and ask this, but Stephen Hobart's asked, are you still a fan of the GCS, or is AVPU sufficient enough, especially pre-hospital?
Oh, good question. I don't. I'm probably not because for neither. Because they're helpful. So if they're helpful in the sense that if you've got that reduced GCS, and that's an acute reduction in your GCS. So if your baseline is 13 already and that hasn't changed, there is probably not much going on. There is probably nothing under the bonnet there that's going to be a concern. And likewise with AVPU, if there's no shift from the baseline, then they're not very helpful. If there is a shift from the baseline, great. But yeah, I would say sort of as we've sort of mentioned, there's more going on with this patient group. So if there's not a shift from their clinical baseline, then there isn't much more to explore
Um,
potentially.
Thank you. Emily Roberts has asked, how do you balance the risks of over triage versus missing a serious traumatic brain injury in older patients?
Uh, yeah, so really good question, and this is a tricky one. So from what we're seeing, what we are seeing, sort of the incidence of intracranial bleeding is quite low, and older adults who have that significant intracranial bleed that needs some sort of emergency operation is even smaller. That being said, we know that these patients end up typically going to trauma units and not major trauma centers because they have quite subtle signs and symptoms. So, but for the vast majority of patients that we see, it's going to be unlikely that they're going to have some sort of intracranial bleed. And I think this is quite uncomfortable for us in the pre-hospital space because what I hear constantly is, well, what if I miss something? I'm going to lose my registration. I'm going to lose my job. There's going to be a serious investigation, and I'm going to be stressing for months. And the reality is that's not necessarily the case. Now, I know that going through a serious investigation is quite unnerving, and there are there are there are issues with how they're potentially handled, and a person's experience with that. Totally understand that. But if you've done a thorough assessment, you've identified the risks both at staying at home and going to the emergency department. You've conveyed that to the patient and or their carers and loved ones, and you've come around and made an informed decision, and you've documented that appropriately. That's not negligent care. That's patient-centered care. And and if there is a bleed brewing in that patient and they've not got any sort of clinical signs and symptoms, and it doesn't really sort of present until 3 days' time, they're not going to get. And I mean, okay, if they're on an anticoagulant, there might be some advice to stop that anticoagulant for 7 days. And there is a trial going on at the moment looking at sort of approaches for stopping and restarting that medication because again, we don't really know the answer to that after a TBI. But it comes down to this: you you are judged on the decision you make on the time. You're not judged on the outcome of that decision because that's quite unfair. And what we don't have currently in the UK, I can't speak for other systems, is if you take that patient to the emergency department because that's what the guidelines say, and then that patient has um, and they fall out of bed and crack their hip. They catch an infection, and then they end up getting sepsis or being in that hospital longer than they otherwise would have been. We currently don't have a mechanism in place to sort of look back at do a root cause analysis and say, well, had that patient not come to the emergency department, um, this wouldn't have happened to them. And by all accounts, actually, they were quite safe to stay at home. We don't have a system whereby I've not heard of one yet where actually we've had a complaint come in because you've taken this patient to the emergency department and you have put them at risk. And we probably need to sort of mature and evolve the system so that the services are sort of linked up to sort of better understand that patient pathway and that patient journey. So it's a really tricky one to navigate. But I would say we are judged on the decisions we make at the time and how well informed those decisions are rather than the outcome.
Thank you. I will just do one more, which is Adam Doyle. Can you comment on mechanism more as regarding an increased AOR? What would you consider significant mechanism in a frail patient? And we can also, if you can, do the rates increase dramatically if you manage to fall into more than one group? That's another question we've had.
Okay, so the first one's a mechanism. So thankfully, this group sort of fell into three broad categories. So that's the fall from standing height, That's the fall from greater than 2 meters. That's usually our younger older adults that are up a ladder or at the top of the stairs and fall down. And then those patients that are involved in a road traffic collision, either as a car occupant or a vulnerable road user, so a pedestrian. Um, so this is where sort of the data's skewed almost because we probably didn't have enough patients in those latter two categories to really bore down into the detail. But essentially, if you've fallen from height, so falling down a flight of stairs off a ladder, then that's worthy of there will be caveats to this, of course, but that's worthy of a trip to the emergency department. Um, the the road traffic collisions, this one's really tricky. So again, sort of low speed collisions. If you're in the car and sort of strapped in, especially in a newer, more modern car, they're particularly safe. But again, if we're looking at sort of greater speeds here, so 30 miles an hour plus, there's going to be sort of more risk associated with that. But again, that also introduces other risks and sort of other traumas as well. And I believe a collaborator of mine, Dr. Claire Baker from Imperial College, she's done some work looking at road traffic collisions and traumatic brain injuries and has presented on a previous trauma care webinars.
Thanks,
So I would
Jack.
definitely go back. I'd definitely go back and watch that because there's definitely richer detail about road traffic collisions, those mechanisms. And sorry, what was the second part to that question?
Do rates increase dramatically if you manage to fall into more than one group?
Into
That's
more than one.
yeah, I think it's more than one risk group. I'm guessing that's that question means.
Yeah, yeah. So yeah, good question. So we probably haven't looked at that in enough detail, and we don't have the patient numbers to sort of really look into that. We need sort of a large data set for that. So no is the answer to that question.
Lovely. Do you want to finish off? I'm conscious of the time. We are going to overrun, guys,
Yeah.
but we'll keep going.
Yeah, sure, brilliant. Okay, right. So we'll quickly just power through this one. So those patients that present out of hours, unwitnessed fall in the care home, what do we know about them? Actually, probably more than we give credit to. So quite an Orwellian study, this one, but an interesting one again from America. So this was 9 years worth of data done in a residential care home where they actually had cameras all over the care home, and they recorded 650 odd patients who were 65 years and older. They recorded just over 2,000 falls, and they looked at how the patients fell, what they fell on, and sort of the risk associated with that fall. Now, interestingly, what they showed here is that regardless of sex or age, the body part with the highest susceptibility of injury and risk, and I'll explain how they defined risk on this, was the least likely to experience an impact, and that's the head. That's a bit of an outlier here. Whereas the most resilient body parts to injury, sort of hands, elbows, forearms, pelvis, they were sort of the most frequent body parts to experience an impact, and you can sort of understand why. I mean, as we get older, when we fall over, there's actually quite a lot in the way of our head before our head hits anything, unless we're close to a wall or whatever else. So, so when you're presented with that older adult, there's probably a fair chance on the balance of probability they haven't hit their head. But again, there will be caveats to that, and really getting down into the detail is quite important when getting that history. Even it's just understanding. I appreciate that fall may not have been witnessed, but just getting that detail from the staff or the carers as to what is their mobility like, how do they move around, what's typical for them, and that will usually give some clues as to, well, if this is what they look like when they're moving, this is probably how they're going to fall, and what they're going to hit first. And just on this one, risk here wasn't necessarily risk of significant injury. This is done in America, and if you call, they haul, with a lot of cases. So this is just the risk of being conveyed to the emergency department. There wasn't any sort of further follow-up information. So that head risk could mean anything. So just bear that in mind. But what about identifying traumatic brain injury in the pre-hospital setting? a lot of interest at the moment in this device in the UK, definitely in North America, and I'm sure sort of in other systems around the world. So the iStat Alinity, they've created a cartridge that takes venous blood, whole blood, and in 15 minutes it can measure TBI biomarkers. And there's two TBI biomarkers that we're particularly interested in. So that's ubiquitin C-terminal hydrolyase L1 or UCHL1 and gliofibrillar acidic protein, so GFAP. So this is this blue one and this green one. And what we see here is these both spike quite early on following a head injury. Now, UCHL1, that's released from the neurons, but it's also released out of the peripheral nervous system. So it's not the most accurate, but it gives us a good indicator of whether or not there might be a brain injury. But if GFAP rises, that's released from astrocytes, so it's a little bit further down on the neuron. It takes a little bit longer to get into the blood, and it's most as commonly associated with the central nervous system. Colleagues, so Dr. James Price from East Anglia Air Ambulance and Professor Virginia Newcomb from Edinburgh, who I believe has again presented on one of your trauma care webinars. They're doing a lot of work looking at the association of these biomarkers in TBI, but there's a good sense that GFAP is associated with a TBI. Now, whether or not there's space in a frontline ambulance for this, those devices are about £7 grand, £10,000 a pop. Each cartridge is £40, and you need to take a venous sample. And I don't know of any ambulance services where frontline crews are taking venous samples as routine care. So this may be something you have at the front door of the emergency department. And if they're elevated, have a scan. If not, perhaps wait and see. So a couple of things to sort of think about there. But what about just a sort of few final thoughts here when we're thinking about older adults and head injury? If they don't have those clinical symptoms or signs and symptoms associated with a head injury, it may not be a case of just taking that battle and passing it on to the emergency department. Definitely in England and wider in the UK at least, it's now about sort of putting those pieces of the puzzle together, understanding what is in the patient's best interest, what they need for that's the older adult that is, and what's best for them, and really sort of bringing those, understanding what the patient wants, bringing in sort of senior colleagues and getting that input as well, and sending them down the right trajectory. Just to finish off, so this was something I picked up from Rory Sutherland. So he's an expert in sort of marketing and in a commercial sense. But he made quite an interesting point in the UK, at least, that we've got websites now, and I'm sure this is true around the world. If you want to buy a house, you go on a website and you look for something of interest. But yet, when you sell a house, we still put a plaque outside it saying, this house is for sale, which seems quite odd. But actually, the reason why we do that is because if you think about it, you might have someone driving in a town they don't necessarily live in. They might see a house they like, see it's for sale, and then go to the website and think, oh, actually, we could afford that house, and I wouldn't mind living there. And then before you know it, they then start thinking about moving. They start thinking about selling their house and, is this a good time for me? And you're creating a market that perhaps otherwise didn't exist. But what's the relevance here with head injury? Well, as I said earlier, we're looking for those classic signs and symptoms with a head injury. We're looking for those signposts. And actually, there might be other things out there that we're potentially missing. And I sort of mentioned this paper earlier with regards to sort of GCS, and the severity doesn't necessarily correlate with a patient's injury. But we've been focusing on GCS. Is there something else to look out for? And I gave a talk some time ago now saying, and never do this. If you're ever talking, never say, I've never seen this, because you'll get called out, as I did. I said, I've never seen anything mentioned about concussion in older adults. It's all about intracranial bleeding. And surely younger adults get concussion. We see it a lot in sports medicine with our athletes. But what about older adults? They're still getting trauma to their head. Never seen it. We're clearly not doing anything about it. And then I got called out on it. And actually, there's been some scoping review that's looked at this and concussion in older adults. And it could be the fact that these patients present, they hit their head, and then they develop symptoms down the line. And it could be that classic sort of, I've just got a fuzzy head. I don't really know what's going on. And it's really ambiguous to us because we don't have any sort of guidance as to how to navigate this. And we perhaps need to be a lot more thorough in our neurological assessments and wider assessments of our patients, and start to look for sort of signs and symptoms that we might not otherwise consider. And if we can start highlighting that in our individual records, we can then pull that together and perhaps look at how better to define other TBIs that we're perhaps missing with these patients. This is getting picked up in primary care quite a lot. Sort of 6 weeks after injury, patients are presenting with, say, a headache. They've got post-concussion syndrome. And while that we miss that, perhaps potentially miss that at the acute stage, that patient is, suffering for 6 weeks with headaches, struggling to sort of do their day-to-day activities. So there could be things we're doing better in our assessment. So I'm going to stop there. Thanks very much. I've not put my email address on this slide, but essentially it's first name dot last name, so jack.barrett at ccam.nhs.uk. I'm on X. Don't use it. I don't sort of post on that anymore for various reasons. You will find me on LinkedIn though again. Yeah, thanks for your time. Happy to take any more questions. I've got a bit of time, and actually, I'm now and then after this, I'm speaking to some colleagues in New Zealand about this subject as well. So shout out New Zealand. Thanks for getting up.
So New
So
Zealand
yeah, great.
people, New Zealand people, you can see Jack twice. Jack, we'll do two final questions.
Sure.
Were there any decisions to take older patients not to take? Sorry, were any of the decisions not to take older patients to hospital guided by comorbid state or respect forms, meaning that they would not be candidates for surgical intervention? That's from a Kath Livingston, an ITU colleague.
Yeah, so we definitely saw from a comorbidities point of view, those patients who were known to have Alzheimer's or dementia, they were less likely to be conveyed to the emergency department. It was it was really tricky to sort of pick up respect forms. So respect forms, end of life care decisions, and clinical frailty wasn't routinely recorded. We had a bit of a Goldilocks effect when it came to clinical frailty scores, in that those five, six, seven, those in the middle would get recorded, and I suspect because they probably got some quite complex care needs, there's still quite a lot we can do for those patients. But those patients who are sort of pre-frail, very fit and well, you think, well, we can see you're fit and well, why would we record that? And those at end of life, again, we can see by other means your end of life that wasn't recorded. So there was lots of, and this was a retrospective. A lot of this work's been retrospectively done. So there are a lot of gaps. So again, my plea to the hundreds of you on the call: take your time to recall frailty scores, ethnicity, end of life care decisions. Yeah, please do detail that in your patient report forms, because while you may not think it affects that one-to-one interaction at a population level, we really do lose the granularity.
And just finally, this is a very personal one from Debbie McKinnon. We're not going to talk about her case specifically. Um,
Uh-huh.
my dad was taken to hospital post-head injury, but didn't get a CT scan. He was GCS 15 and asymptomatic. However, he had alcohol-related brain atrophy, so by the time he was symptomatic, it was too late. His eventual scan was terrible. He was super fit in his 70s and still working as a bricklayer. However, I'm left wondering if an early scan would have had a different outcome. We won't talk about that case specifically because obviously
Mm.
this is about generalities, but you do get brain atrophy in older people, and that means that. Sorry, I should mention I'm a neurointensivist in my day job. You do get that additional space for blood to fill before you get a change, and one of the things in neurointensive care is if you've got a GCS drop of one or more, that's enough to go and do a scan because GCS is an incredibly sensitive test in terms of you don't wait till GCS of 8. A GCS of 14, a drop of one or more will warrants a scan. And you talked about concussion, and one of the things I teach the neurosurgeons is a GCS scan of one or more dropped at scene plus a normal CT head equals concussion at any age. Do you want to talk through where taking that knowledge from in hospital and scans and how you've translated that into the head injury guidance? Because there were a few general questions around over triage, under triage. Where does GCS fit into all this? How sensitive it is?
Yeah, it's a really tricky one, and thank you for sharing your story. But for the GCS, what we've got to remember, a lot of our evidence base and what we lean on is on the what's been recorded in the emergency department. And from our point of view, and I didn't share this slide, what we've got to consider is in the patient population that we see, we are seeing patients that go to the emergency department and don't go to the emergency department. And we've not developed the evidence base to really help us understand who those groups are. We only see the ones that end up going to the emergency department. Now, yeah, GCS and that clinical presentation is really important. But as we've seen in the literature, in our trauma registries, and through our experiences, is that GCS doesn't necessarily change, and there are other things we need to be cognizant of, and we perhaps don't yet know that. And this is why it's really important that we as healthcare professionals on the call are research active and contribute to the knowledge base. And it's really tricky at the moment because let's face it, if we went to every patient, our pre-hospital colleagues here, and did an ECG on everyone, you will probably find something coincidentally. But if there's not an indication to do it, it's that balance and risk of exposing someone's chest, putting chest leads on them, and so on and so forth. But until we better understand the patients we serve and spot those signs and better spot those signs and symptoms, we are unfortunately going to miss things. So yeah, it is a real tricky one, and we're always trying to evolve and better our knowledge.
Brilliant. Thank you, Jack, so much. There's been a huge amount of love on the chat. If you please go and scroll through that, you'll enjoy that. Everybody's been very, very appreciative. We peaked at 424. Very interested people from around the world who are very interested in hearing from you, and we're very grateful to you for your time today. I'm just going to finish up with the finishing slides. Tom, if you could put them up. So this is the QR code, guys. Please scan the QR code if you're not a trauma care member, but you would like a CPD certificate for this webinar for your portfolio. If you aren't a trauma care member, why aren't you a trauma care member? You should be a trauma care member. It's through our members that we know what you want to hear and deliver that. And I'm just going to talk about a few people that we have coming up. He says, having just lost the email. There we go. So we have in May, we have 21st of May, we have Resuscitation in 2050 by Professor Gavin Perkins, who is the chair of the Resus Council. We've got some fairly big hitters coming up. On the 18th of June is Fionn Davis talking about minor injury in children. And the tagline is, "You've read the book, now meet the author." She literally wrote the book on minor injuries in children. And on the 16th of July, we've got the amazing Gareth Davis, who talks about medical lessons from the Isle of Man TT racing. For those of you that do know me, you know that I've been working in motorsport for a long time. Bikes scare me, and I don't know how you guys cover bike meetings because there's just too much work for that. Nikki, thank you for your shout out for my t-shirt. This is a classic trauma care t-shirt that I've decided to wear today from a few years ago. Please do become a trauma care member. It is less than a cup of coffee per month to join. You will get access to the quarterly trauma journal as well as discounts to the conferences that we organise, and there are other benefits that you will also see. Oh yes, if you don't just want your certificate and you wish to donate to trauma care, we are a charity. We do depend on donations and memberships to keep doing all of this. So please do donate to trauma care if you feel able to do so. I think that's all the slides, Tom, isn't it? Yes, it is. So thank you very much, guys. Very much, very pleased to see so many of you. Please do join Trauma Care and support our journey forwards. And thank you again to Dr. Jack Barrett for his time and his fantastic information that he's given us today. Thank you.
Pleasure. Thank you, everyone. Been great fun. Have a good day, night, week, whatever. Take care.
Brilliant. Thanks, Jack. That's really, really, really appreciated.